I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. It's my great pleasure tonight to have Dr. Alex Barkin, who's the Chief of Bariatric Surgery at Richmond University Medical Center, here with us. Bariatric surgery has become a very big deal, whether it's on reality shows or whether such as the 600-pound person, or things that are very relevant to people in the community. And I know that you've recently come to Richmond University Medical Center,
Right,
bringing together some of the newest techniques that are involved. Our population is getting heavier over time. And really, the idea that bariatric surgery is helping patients with multiple medical conditions and being able to, such as diabetics, and really trying to change their lives really has become a new thing. So let's talk a little bit about what bariatric medicine and bariatric surgery is. So you're a bariatric physician, bariatric surgeon.
Right.
Tell me, what training do you have to get to be to this point?
So being a bariatric surgeon, you go to medical school and then you have a general surgery residency, and then you specialize in bariatric surgery. And bariatric surgery expanded from laparoscopic surgery as surgery evolved from big open incisions to small incisions. Bariatric surgery became very popular, because now you can do surgeries on large individuals with minimal cuts and not a lot of stress on the body. So it evolved into what it is today, and it's become a standing profession.
So it's part of surgery, and it's a specialty of surgery that you're training.
Currently it is, yes.
Tell us a little bit about the team approach that you have with bariatric surgery. If somebody, and not to go back, some of my, seeing you, of course, at the hospital recently, and all the wonderful work you're doing, the idea that when people do watch a television show and see a physician and someone who's very overweight, morbidly obese, right, the idea of how does someone get from that point to someone like yourself? Does their internist refer them? Do they refer themselves? And what team do you have?
So that's a very interesting question. Even today, most of referrals are self-referrals. A very small percentage of primary care doctors or internal medicine doctors are well versed in bariatric medicine, bariatric surgery, because in the past, when it first became popular, bariatric surgery had some negative connotations. There were some complications because people who were practicing were general surgeons. There was no specialty yet, and so they were practicing bariatric medicine because they were surgeons and they thought they could do this as well. But they realized that that wasn't working, because bariatric surgery requires a team approach. Today, bariatric surgery consists of a full team, a bariatric surgeon. It consists of a coordinator who runs the program, who makes sure that the patients go through the necessary workups. And the workups are usually very extensive. They include heart workup, a lung workup, a full set of labs, endoscopies. So all doctors have to be involved, including internal medicine doctors, psychiatrists or psychologists, and nutritionists. So before the patient even receives surgery, the patient has to have all this workup done, and all these consultants have to specify what they think is the person's situation or needs, and what will happen after surgery as well, because this is a continuous process.
So let's talk about just words. So there's people who have normal weight, overweight, obese, morbidly obese. Right. Maybe you can go over some of the definitions that you guys use, and even the idea of what BMI is. We hear this so often, BMI.
So body mass index is the gold standard to determine qualifications for surgery. It consists of weight and height, and it goes into a formula, and a number comes out. Normal BMI in our society, or any society, is 18 to 25. It's considered to be normal. But in American society, it's only about 35% of the population. Between 25 and 29, you're considered to be overweight. Above 30, you're considered to be obese. And above 35, you're considered to be morbidly obese, which qualifies for surgery. Between 35 and 40, people have to have other medical problems, such as diabetes, such as cholesterol problems, such as high blood pressure, joint problems, sleep apnea. And sleep apnea is basically if you find yourself snoring at night, or you're falling asleep in a chair, or your significant other feels that you stop breathing, has to give you a nudge, and the person hasn't been tested for it. They have to be tested for sleep apnea to determine if that's what they have, and they require a CPAP machine which helps them sleep at night. So it's a very comprehensive workup that's necessary prior to undergoing surgery.
Is there any age group of people that are excluded or included? Or you could be too old for the surgery, could you be too young for the surgery?
Well, I think teenagers, in terms of teenagers, we look at bone density. If their bones are matured, then they qualify for surgery. If their bones are still maturing, usually surgery is not offered at this point. And for teenagers, surgery requires a multidisciplinary approach. The pediatrician has to be involved. The patient, we have to determine that the patient is mature enough to understand what they're getting themselves into, because it does require a change in lifestyle. It does require a change from what they're used to. So that requires a more extensive workup. But we have operated on children as young as 14 years old, and we've operated on people as old as 80 years old. So really there isn't an age limit to these surgeries. There's a large spectrum of patients who can undergo surgery.
So tell us a little bit about, with regard to the surgery itself. There were multiple different surgeries. And maybe I'll ask you even a different question first. Sometimes people will say, if I go to the surgeon, you're self-referred, they're always going to do an operation. And as a neurologist, I deal with a lot of spinal issues, people with herniated discs. And many of the surgeons that I respect most are the ones who, when I send someone in to have these evaluations, many times will say, let's do conservative treatment first. In your practice, are you seeing a lot of patients that aren't requiring surgery, that might be candidates for diet or other interventions with a psychologist? And again, there are different types of things. And tell me about this gamut. Or is everybody, by the time they get to you, someone who really does need the surgery?
The average person takes 2 years to make a decision to come to bariatric surgery, and even that they're still very nervous and still afraid. But most people who've come to bariatric surgery have tried dieting in the past and were successful with dieting many a times and lost significant amounts of weight. But statistically, weight gain recurs within 2 years, and people usually add more pounds than they've lost, because dieting does not work for the most part. Of course, a person who comes to us, particularly a younger person, who is on the fence about decisions about bariatric surgery, we do not just force them to have surgery. I encourage them to do other things, such as traditional exercise and dieting and behavior modification. So I never worry about, I never feel that I have to push the patient to surgery. If the patient is not ready, I'm the last person to try to talk them into having surgery.
So the idea of what procedures you have available, they've changed dramatically. I mean, and as I said, my information is for me from 5 or 10 years ago, or even longer when I go to medical meetings for it. But every year when I hear you give grand rounds or hear people talk about it, the number of procedures has changed. And thank goodness, as all of surgery, everything's becoming less and less invasive. Some of the things not even without a cut, endoscopically. You could tell us a little bit about what's available to patients, and maybe even we'll go step by step, who might be eligible for which. Because there are so many people who we've now seen who have had different procedures who, for some reason, they say it didn't work. And you'll tell us about the success rate. But tell us, how do you decide which procedure would work for someone?
So currently there are 3 to 4 procedures that are standard, and the reason they're standard is because they are also covered by insurance, and that allows a lot more access to patients to decide on these surgeries. The ultimate decision is the patient's decision, but there are some situations where we offer one surgery, or we think that one surgery will be better than the next. The 3 major surgeries that are offered currently are lap band, a gastric sleeve, which is really a misnomer.
Even the lap band, let's go start very early. So we have a very smart audience.
So
and everybody out there knows everything, but still, I don't know what all these things are. So explain it to them.
I actually have some pictures.
Oh, please, pictures are worth 1,000 words.
So as you see here, this is the lap band. This is normal anatomy, the stomach, the liver, and the intestines. The lap band, which is basically a rubber device, and the analogy I use is that it's sort of like a bicycle tire, where you have the actual tire and then you have the inner tube. That inner tube is connected to a catheter, which connects to a device called a port, which sits under the skin, and it's not seen, it's felt if you press deeply, but otherwise you can't see it. And salt solution in the office is injected under local anesthetic, and this is an office procedure. The adjustment is, this is a surgical procedure for the most part. So we adjust this inner tube, it increases in size, and it narrows the esophagus where it enters the stomach, and it causes sort of a traffic jam. Food goes from a 4-lane highway to a 1-lane highway, and it trickles down slowly into the stomach. The patient actually feels the food coming down. It's a little bit difficult to eat, and that's sort of when the band is working. And that allows the patient to slow down the rate at which they're eating. It should chew approximately 20 to 35 times before swallowing, because the esophagus is a muscle, and after a certain amount of time of it peristalsing down, it becomes tired like any other muscle, and that helps in satiety. So that's or feeling full. So the patient has to eat slow. The patient has to have small meals and get full and stay full. That's the goal with the band. If they're hungry or looking for food after they had the band, then they need an adjustment, which we narrow again. We squeeze the esophagus, making it a little more narrower. But of course, there's a limit to what we can do, because we want the patient to have a comfortable lifestyle. And that's basically how the band works. All these surgeries, including the band, is done with small incisions, very small, 1/2 centimeter to 1 centimeter incision. And the band surgery is a same-day procedure. It was very popular in the early 2000s, and it slowly has lost its flair from the past, because more data is coming out, and we're realizing that the band is not for everybody.
Because it doesn't work for everyone? Or
It doesn't work.
complications?
It doesn't work for everyone, because depending on the body mass index of the person starting, and also its complications. Now, the number one complication with this procedure maybe is some nausea, but with time, scarring occurs where the band is sitting, and it causes a narrowing. The stomach above it can increase in size, and it causes reflux. It can cause reflux, it can cause difficulty in eating, and actually continuous pain. And sometimes we have to go in surgically, readjust the positioning of the band, or sometimes we have to take it out. And also sometimes the weight loss initially happens, but then people stop losing weight or regain the weight they lost. So really, the weight loss is really all over the place with the band, and it's hard for the physician to determine who will be successful with the band and who won't be. So it's sort of slowly falling out of favor as a procedure of choice for weight loss surgery.
So what other procedures do we have?
So other procedures that we have that are more that have become popular is the gastric sleeve. So again, normal anatomy, here's your stomach, here's your liver and intestine. The stomach can hold about 1 liter of fluid, like a Coke bottle. What we do is we cut away a portion of the stomach, approximately 70% of the stomach, and it's a blind balloon, so it has to be removed out of the body, and it becomes a permanent surgery. And the stomach is in the shape of a banana or a shape of a hockey stick, where you have it sort of thin on the top, a little wider on the bottom, and that's what you're left with. So gastric sleeve is really a misnomer. It's just a narrowing of the stomach. And again, this surgery is done, again, laparoscopically or even robotically with small cuts. And this surgery has become popular. About 70% of procedures today for weight loss surgery is a gastric sleeve. And patients who undergo a gastric sleeve, usually patients who want to undergo a gastric sleeve, or patients, for example, who've had other extensive surgery in the abdomen, can have scar tissue, and you don't want to manipulate the intestines so you don't cause damage, then a sleeve is an option for these patients. And that's
you said this is the most
popular.
common procedure?
The most common procedure today.
And is it the most effective?
No, the most effective procedure is the gastric bypass. It's a gold standard for weight loss surgery, which we'll mention in a second. But the thing about here is only manipulation of the stomach. The stomach is just made smaller. The gastric bypass, which is the oldest surgery available to us, it's about 60 years old, and it started when doctors were noticing patients who had ulcers in their stomach, and there was no medication at the time, who developed complications with bleeding or holes. They needed emergency surgery, and so they needed to cut the stomach out, and people started losing weight. And so doctors sort of decided, let's form a surgery to see if we could work for weight loss. And it evolved into what it is today. And it consists of 2 parts. It's called the Roux Y, like the letter Y. One part of the Y is connected to the new stomach, which is about the size of an egg. And this part of the bowel, which connects to the new stomach, food is not being absorbed there. And then the other part of the Y connects to the old stomach, where the intestinal juices and acids and pancreatic juices flow for help to digestion. Where the Y meets, that's where food starts to be, again, absorbed. So it's called the Roux Y. You have a small stomach, size of an egg, about 5 centimeters in size, and then you have about 2 feet of bowel that get bypassed where food is not being absorbed. And the reason this surgery works is because patients are not hungry. And again, minimally invasive, small incisions, and patients do very well. So this is the gold standard. This is considered to have the most significant weight loss of all the procedures.
And people could have these procedures for years? Is there a time limit to when you have to revise them?
So ultimately the answer is yes, they can have this for years. Revisions occur for several reasons. The pouch can increase in size slightly, but usually it's not that big of a deal. The opening between the intestines and the stomach can increase in size, and that sometimes needs to be revised or somehow changed. And very rarely does this portion have to be revised as well. But for the most part, people have the surgery once in their life.
Tell us a little bit about the complications. So, I mean, you mentioned this gets bigger, that gets bigger,
Right.
there's some scarring.
Right.
But surgery has changed over the years.
Right.
I mean, shorter procedures, less invasive procedures, as you mentioned.
Right.
Tell me about if a patient comes in and decides on one of these three procedures. I know they all have slightly different side effects or different complication rates.
Right.
What are the major complications that you see with these procedures?
So, medicine works on data and works in evidence-based medicine. So recent data, because most bariatric centers today are standardized. They all have data collection and they all have designations, which we are aiming for that as well. And the data allows for extensive research. And so recent research of over 100,000 people who underwent surgery, they looked at all the complications that can possibly occur. They looked at 150 different factors. And they looked at anything and everything that any physician can ever think of. And what they came up with is the number one complication of all these surgery is nausea. Patients can be a little nauseous after surgery for a few days, but usually it goes away and it doesn't come back. Things that are individual issues that can happen with particularly a sleeve, for example, is reflux. Sometimes reflux can occur sleeve, and patients who have reflux prior to surgery and have a condition called a hiatal hernia, where it's sort of a little wider opening of the diaphragm where the esophagus comes into the stomach, we look for that during surgery and we fix that and it helps with the reflux. But reflux can be an issue. As well, sometimes constipation. If they don't drink enough fluids, they can be a little constipated with the sleeve. With the bypass, one major issue that can occur is something called dumping syndrome, where you eat something very sweet or something very fattening. Yeah, patients get a little crampy, maybe a little sweaty, and they have to go to the bathroom an extra time. And those usually occur due to certain foods that they eat, and they realize what it is. They stop the food, and that goes away. So that's specific to the bypass, as opposed to the sleeve. So those are the sort of the mild complications. The worst complication of these surgeries, which is very rare, because today bariatric surgery is just as safe as gallbladder surgery, statistically. But there's something called a leak. If there's a hole in the anatomy for a technical reason, that may require further hospital stay, further surgery, other procedures. But for the most part, patients eventually do fine and leave the hospital or even are home while they're going through this. But it can be very uncomfortable. But those are the worst complications, and they're the rarest complications. And particularly today, because bariatric surgery has become a specialty rather than just anybody who's a surgeon practicing.
Interesting. Something that we spoke about before. When I was a medical resident, there were a lot of emergency room television shows, and I was working in an emergency room at the time. I never liked watching them. Then when Dr. House came out, being a neurologist, there were always neurological cases. And my kids used to call me the Dr. House because I know a little bit what would happen. Sometimes I didn't always agree. When you see television shows like The 600-Pound Person, what's your opinion about them? Do you think they're accurate in their portrayal of what the procedures? And not to talk about another physician, I don't even know the name of the person. But is it something that when people look at on television, they get the right aspect of it? Is that really what bariatric surgery is about, or is it really not?
So this shows what they do, and I think that's very important for the everyday person, is they sort of integrate the surgery with everyday life. People who come to these shows or come to these doctors or come to me, they have a life that's going on. They're either people that are truck drivers, or they're people that sit at a desk all day, and they have a life. They have families, they have kids, and they want to live their life. And what happens is sometimes they gain weight, and this affects their life. And so they're using medicine and surgery to get back to their normal life. So I think for the everyday person, this is a very good thing to watch and see, because you see the integration of medicine and everyday life. So to allow the person to go back to their life. The technical parts and the medical parts of the surgeries, I guess, is more for the physician to appreciate and understand. But the surgeries are accurate. There are the gastric bypass and the sleeve is sort of offered all over the country, as long as the patient meets the criteria. So I think that this portrayal, for the most part, these documentaries are pretty accurate.
So tell me, people sometimes gain their weight back.
Right.
You talked a little bit about the lap band and some reasons that might happen. Why do people, and we've seen people, again, maybe they might be the exception, maybe you can give me some statistics. What percentage of people do gain a significant amount of the weight back? And is there a reason specifically they do?
So weight regain is normal after these surgeries, after a certain amount of years, and we're talking about 10 to 15 pounds, maybe a normal phenomenon. If a patient is gaining 30, 40, or 50 pounds after surgery, they usually know why. Well, these surgeries come with specific dietary recommendations. If dietary recommendations are liberalized, then of course you can regain the weight, because what happens after a while, the anatomy settles down, and now this pouch and this intestines all act as a reservoir together. So if you do something called grazing, where you're eating all day, or you're eating high-calorie foods, or foods that go down easy, for example, high-calorie drinks, or ice cream, or milkshakes, or anything that has high calorie but is very soft and can go down easily, those are empty calories, and that will lead to weight regain. So weight regain actually is not common, but to some extent it happens to all patients. And so for the most part, when you talk about success, I would say in my practice, probably it's close to 70% of people maintain their weight within 10 to 15 pounds. There are some that do regain weight and do need other procedures done, or need a revision or conversion to another procedure. So any patient can fail these surgeries if they really want to. But the amount of work it takes to have the surgery done, the amount of workup, and also we have a very tremendous support system. We have support groups for patients every month that they come into. We give different lectures on different topics. We're available 24 hours a day, 7 days a week. So we have a very comprehensive program, so the patient doesn't feel alone, that they're out in the world after surgery too. So that helps as well. But weight regain can occur.
In the medical literature that I'm reading, and again, clearly on the high level that you talk about with bariatric procedures is one thing. There's been a lot of talk about endoscopic procedures, where some tube is put down and some procedure is done. Do you do them? Do you agree with them? Do you think they're as beneficial?
So there are several new procedures out. One is called the gastric balloon. So when the gastric balloon was coming out, people were very interested, intrigued, because it was promising to have very good results. But the issue is with the gastric balloon, for example, that it can only stay in the body for 6 months. We know from bariatric data, we know from lab band data, from even any of the surgery data, we know that if you take the lab band out from a patient who even lost weight, maybe even 100 pounds, they will regain, 99% of people will regain their weight back. So these procedures are not covered by insurance. They're pretty hefty in terms of payments and most people don't have money laying around that, to pay for these procedures. So what happens when you take the balloon out in 6 months? You're going to regain the weight back. So my opinion of those procedures is that they're temporizing procedure. They maybe are good for patients, for example, who have a very large weight, who maybe need to be safer for surgery. Their weight has to go down significantly, and such a balloon can work, but insurance does not cover that. For a person who needs to lose 20, 30 pounds, the balloon, it may be an option, but it's a very expensive procedure just for those 20, 30 pounds. So I'm not a big proponent of these procedures because of the cost that the patient has.
And it's also not a long-term benefit.
And it's not a long-term benefit. The other procedure is called an endoscopic sleeve, which is also available nowadays. Again, it's a new procedure. The sutures are done endoscopically, and the procedure does work. But the question is long-term results. We don't have long-term results. Do the sutures come apart? Does the stomach swell? In the past, any of these procedures never really worked from whenever they were introduced. But again, it's practiced now, it's offered now, and it's an out-of-pocket expense. And some patients will go for that because if they had extensive surgery in the past, or they're terrified about surgery, that might be an option for them. Another procedure that's available called the V-block, and basically what that is, like a pacemaker for the heart, you sort of attach the paces to the vagus nerve, which supplies satiety and appetite, and it blocks the electric potentials to stimulate appetite. So patients are not hungry. But again, there are issues with that device. It's a bulky battery. Patients have to bring the equipment with them when they travel to adjust. So it's not it sounds like a great idea, but it's not a great idea for everyday life.
Alex, I'm thrilled that you finally got to nerve stuff. That stuff I know.
Yeah.
Vagal nerve stimulation we use for epilepsy, we use for depression. So even right now we're being used for migraine headaches. So that vagal nerve is actually something that's being used in a lot of different ways. So I'm glad we found, everything always comes back to the neurology of this. So tell me about cosmetics. So if someone loses a lot of weight, when you have your team, do you have part of your team someone who could help the patient cosmetically with skin that's overhanging or things that might not look as nice after a dramatic weight loss?
Sure. Yes, we work with plastic surgeons very closely to offer patients these procedures. The biggest question is, does insurance cover them? And the insurance may cover an abdominal plasty or removal of skin around the abdomen. Of course, the other cosmetic procedures, such as arms or thighs, that will require more of an out-of-pocket expense. But we do work with plastic surgeons to offer patients those options.
Just some generalities. There have been medications out there now for weight loss. And I don't know, being a surgeon more than someone involved in on the medical side of it, what's your opinion about some of the medicines that are out there? There's over-the-counter medicines that help reduce absorption of fats. There are medicines that help reduce cravings. In your experience, what is your feeling with that?
I think that these medications are associated with lots of complications and side effects. Not complications, but side effects. All of them have side effects. The medication that prevents absorption can affect the stool. The medication that stimulates or controls hunger can cause anxiety. The medication that works on the brain to control hunger can cause depression. So all these medications have side effects. Some of them cause nausea, some of them cause vertigo. None of these medications are free, meaning not free in money terms, but free in terms of side effect terms. So no medication has been developed yet that is very effective. There are some on the market that are better than others, but for the most part, these medications should be used with a grain of salt, and patients should be told to use them with caution.
And it's interesting, there's a concept in neurology, no brain, no pain. So if you don't have a head, nothing will hurt. Right. You also won't in the brain are certain receptors that deal with regard to satiety, being full, and that feeling. So there's a lot of things that are going on in my field. We even have something called a transcranial magnetic stimulator, TMS, where it's being used, and it's an FDA-approved process right now, but a lot of research out there with this TMS machine about stimulating parts of the brain to reduce satiety. And the preliminary literature looks good. Clearly, these are not for people with morbid obesity, because it really won't work as well. Do you have any experience with any of those very cutting-edge, different kind of things?
I personally do not have experience with them. I think that we're trying anything we can to help with obesity, because it's such a great problem in our society. The issue is that obesity is associated with over 250 genes associated with obesity. So to pinpoint the exact cause and to pinpoint the exact is very difficult. Things that you're describing are just another procedure on a spectrum that's being offered to patients. Because patients are still afraid about surgery, they're nervous about surgery, and so despite the fact that surgery is very effective, only 1% of the people that are eligible for surgery will undergo surgery, only 1%. So in America, about 22 million people are eligible for surgery, and only about 200,000 a year get surgery. So surgery is still a very, in infancy in terms of application for weight loss.
Do you think people should be going to you guys more, meaning bariatric surgeons, in a sense? I think people are afraid to go because what the results of the consultation will be. But clearly no one's forcing anyone to have surgery, and I think people learning their options is so crucial. And do you get people who just come in to ask questions about it and whether they really want it or not? You said such a small percentage of people do it. We have maybe 30 seconds left. Maybe just maybe even look right at the audience. What should they know, and when should they think about coming to someone as expert as yourself?
So we offer free seminars every month, and we do not pressure anybody to have surgery. We offer the information for patients, and patients decide on their own what's good for them. If they qualify by BMI, then they qualify for surgery. The rest of the decision is up to them. We will offer them consultation, we will offer our advice, but we'll never force people to have surgery.
And I think that's marvelous. I mean, that's what we're doing here with education, knowing that these procedures are available, taking the stigma away from them, taking the fear away from them, and especially talking about these procedures are no longer what your grandma used to have when they open her up for gallbladder surgery. Correct. These are very robotically done or laparoscopically done, and patients doing very, very well with this. And it's really nice to hear that we're able to handle a lot of medical conditions with it. Yes. Alex, thank you so much for coming.
Thank you very much.